I'm Dr. Kim Dennis. I'm the Chief Medical Officer and co-founder of SunCloud Health, and we are an integrated treatment center serving adolescents and adults in the Chicago area and in Gaithersburg, Maryland. We offer IOP, PHP, and residential levels of care, including a specialty residential unit for adults for patients who have co-occurring eating disorders and addiction. One of the other services that we offer here at SunCloud Health is interventional psychiatry. We have a Dr. Krisanandappa is the head of our interventional service, where patients who are in treatment with us or even outpatients can receive TMS and esketamine or Spravato for treatment-resistant depression. Tammy, do you want to just do a little bit of housekeeping in the way of making sure people know how to get their CE for this educational event, or CME, and then what to expect in the way of enduring content if people need to step out?
Perfect. Yes. Well, welcome everybody. We're excited to have you here. This is a really great event. I'm excited to have Dr. Fenton speak. After this webinar, you're going to receive an email from me. There'll be instructions on how to link to a Medco, which is where you'll be getting your CME-CE from. Once you do that, you'll take a quick survey, and as soon as you're done with the survey, you will be able to print your certificate. So it's pretty quick, and I get those out as soon as the seminar is over. So you'll have that within 10 minutes you'll receive an email from me within 10 minutes of the webinar. There'll also be information in there about the enduring event. So let's say you want to watch it again, or you know somebody that could benefit from it. You can have them go ahead and watch that on our website. It does take us 2 weeks at the most to get that up. So give us a little bit of time. We like to make sure we go through, look at the video, make sure that it's the audio is really great so everybody can hear it. And then we put that up on our website. Once you're done watching it, you'll click the link to the test questions, the survey, and you'll be able to print the certificate. Also, you can look at our website, and there's going to be other courses coming. We're going to do a whole series next year. So once a month, we'll have a lot of courses, and we hope you guys come to see them.
Yeah, thank you so much, Tammy. So I'm going to introduce Dr. Fenton at this point, and just share a little bit about how I learned of you and your work. Dr. Rebekah Fenton is a pediatrician and adolescent medicine specialist at Alivio Medical Center in Chicago. Her clinical interests include providing primary and specialty care for adolescents from marginalized communities. She completed her fellowship and Master of Public Health at Lurie Children's Hospital in Chicago at Northwestern. She received her BA in Human Biology at Stanford and attended medical school at the University of Pennsylvania, completing her residency in pediatrics at Seattle Children's Hospital. Dr. Fenton's work is focused on making healthcare more accessible for racially and ethnically marginalized youth. She also participates in advocacy to reduce experiences of discrimination against marginalized communities by promoting cultural humility, health equity, the practice of weight-neutral medicine, which is why we're here today. We're here today for all of it, really, because it's all connected. The patient and also improving patient and doctor communication. She frequently writes and speaks about general adolescent health topics, healthcare inequities, diversity and inclusion in the physician workforce. She presents at national and international conferences, and her writing can be found at the Washington Post, Forbes, Newsweek, as well as several blogs. I happened upon your writing, when the lights go down after, everybody else is in bed and the day is wrapped up, is when that's when I read medical journals and I don't know if it was MD Edge or MedPage, where I was so delighted and so impressed to see your piece on weight stigma and the practice of weight-neutral medicine. It is sorely, sorely needed, especially among pediatrics and adolescent medicine docs. and all the advocacy work you do and the interconnectedness of weight stigma, particularly as it impacts Black communities, Brown communities in our country. So I'm honored that you agreed to be a speaker today. I can't wait to hear your talk. And with that, I will turn it over to you. We'll save the last 10, 15 minutes for questions and answers. So if you want to, like 5 more minutes kind of sign, let me know and I'll do that for you.
Thank you, Dr. Kim, for having me. I think I actually planned maybe to try to see if it'll fit within an hour. So even I know that we have an hour and a half today, I imagine there's going to be lots of questions and I'm happy to discuss them. And I'm really grateful for this presentation to kind of put my thoughts about this together. I feel like I've had a chance to kind of in smaller formats talk about these things, such as on Twitter or the article that you referenced, but this was really exciting and much needed for me to kind of formalize this. So thank you for giving me that opportunity. And of course, thank you everyone for being here. I actually first just kind of wanted to really push people even in the title of this by saying obesity is not the problem, because often a lot of what we're hearing, especially after those AAP guidelines really formalizing this, we're kind of seeing the opposite message. And then certainly this is all grounded in stigma, and particularly for our children and adolescents. And I think you already heard some details as far as the CME, but just as a reminder for all who've registered that you'll be receiving a link to a survey that will then allow you to receive your credit. And thank you all for being here. I'm really excited about just even the interest in this topic. I also just want to acknowledge that I approach this from a personal perspective, and I think that that's what makes the work that I do come from an empathetic place. And I remember growing up, actually didn't thankfully have to think about my weight, even though that was kind of the only health issue that I had. My pediatrician actually never really brought it up when I was gaining weight in high school. But yet in college, I was in a human biology course, and I specifically remember the lecture on obesity and how it had very stigmatizing images of people at higher weights. They always seem to be eating a burger as if nobody else is eating burgers, but somehow when somebody at a higher weight's doing it, we're like, they shouldn't be doing that. That's the reason why that they're in this position. And also just hearing risk factor, risk factor, risk factor, and just kind of in my seat wanting to just like disappear, basically. So I remember actually texting my brother saying like, I really just wish I could run out of this classroom and go to the gym, because that's how awful that I felt hearing all of these topics, and yet knowing that they were being presented in a way as if it didn't apply to anybody in that room. And so actually that was the first kind of was my final straw towards the first time that I've lost weight. I have had a history of yo-yo dieting, and we can talk later about the negative impacts of that. And so was actually really proud of myself when I had lost a certain amount of weight. And yet, a few months later, for the first time ever in my life, skipped my period and knew enough as a pre-med to be like, wait a second, this is not normal, this is not healthy. And so even saw these impacts in myself pretty early. And so then I applied to medical school, as we all know, requires traveling around the country, going to lots of dinners, wasn't able to exercise, wasn't able to maintain my eating, and so regained that weight. And actually had seen my primary care provider at the time that I lost weight, and she praised me for all of my efforts, and then came back a year later where I'd regained the weight. Epic actually pops up an alert that basically says, like, warning, this patient has gained such and such percent of their weight. And I saw this over her shoulder, and she was absolutely silent. I started crying, feeling like, okay, clearly even the chart is shaming me for what we know is often a very common thing, 90% of diets failing. And yet my provider had 0 words of comfort to say to me. And that actually, I did not go to a primary care visit for 5 years after that point, because I was so afraid of having that same conversation, either on the negative side or just even realizing the absence of comfort is also a negative experience. So I get to medical school, and we're supposed to have a lecture about obesity. And I'm very curious because of the fact that I have had challenges with it. So as my family members, like, how is this going to be addressed? And so the panel includes a patient undergoing bariatric surgery evaluation, a physician who works within the bariatric surgery program, as well as a surgeon and a coordinator. And I just felt like this focus on bariatric surgery, while certainly an option for treatment, was not the full breadth of experiences of obesity. And worse, the faculty member who's introducing the lecture starts off by saying, I know that you all don't struggle with weight, and then continues to say how this is a challenge for patients. Again, really erasing the fact that we as providers may also be experiencing these same health conditions. I actually did approach him afterwards to be able to share my critique and the fact that I actually do qualify as obese based off of my BMI. And I still remember the fact that he actually looked me up and down to assess whether or not that was true. And I think, again, the face of obesity, again, is often people at these very large weights and large bodies. That certainly falls within the spectrum. But that actually, the reason why these obesity statistics are so high is because it does include people like me who often don't get recognized physically as obese, which then just goes into the idea of, is this really a medical classification, or is this really more of an assumption that we're making based off of visual appearances? So after all of these experiences and many more, I went into pregnancy quite nervous because I knew, having been on the other side as the resident writing notes, that BMI of 30 or greater was going to be on my problem list when I delivered in the hospital, and worried that I would be at higher risk for things like gestational hypertension or gestational diabetes because of my family history, because of my weight. So I was very adamant about making sure that I exercised throughout pregnancy. I actually was in a Zumba class 2 days before I delivered, and gratefully did not experience any of these often weight-related concerns within pregnancy, and yet saw friends of mine who did not have those same supposed risk factors experience those challenges, which really just goes to the point that I'm hoping you all get out of this today, that really it's more about the activities and the efforts that patients are putting in, also recognizing those genetic predispositions that make them more at risk, as opposed to an assumption that just because you're living in a higher weight body automatically means that you have these health conditions. And so I was very grateful, and now actually have a now 5-month-old who was almost 10 pounds, and our pregnancy and delivery experience all went very well. All right, so wanted to then divide up our topic today into kind of 4 areas. One, of the history of obesity and BMI, and realize that these concepts were not always in existence, and how they started is actually very less medical than you may have assumed if you've never heard this before. Then going into the controversial topic of this year, which was the obesity management guidelines from the AP. I also added in one slide since I sent this in, because actually just this Tuesday, the USPSTF released their guidelines, and I figured you all were very curious to hear about those, or my comments on those, so I've included something about that as well. And then really my journey of learning how to shift away from the obesity paradigm, and realizing that I actually have to pull quite a bit from non-medical literature because of the fact that the history of these are often actually not medical topics. And then finally, kind of what do I do in practice, at least as a clinician within primary care / adolescent medicine, with hopes that my experiences can apply to whatever work that you're doing. All right, so getting started. First, just defining in terms of what even is obesity. I think it's interesting to see that different organizations actually have different definitions. So the CDC is just saying, hey, it's a weight that is higher than considered healthy for a given height. And even just that idea of what is healthy is all really dependent on the math that we'll get into. The World Health Organization similarly says it's abnormal or excessive fat accumulation that presents a risk to health. Whereas the AP really kind of directly is defining obesity purely as a calculation, saying it's defined as a BMI at or greater than the 95th percentile for children and teens, and comparing that to their age and sex matches. So the body mass index, we'll talk about how it became, but it's basically a calculation that uses their weight in kilograms divided by the square of their height in meters. And really the CDC is the one that's pushing this idea that it's just a screening tool for those weight categories that might lead to health problems, as opposed to it being a problem in itself, or the assumption that that higher weight automatically means health issues. And in adults, we use that BMI greater than 30, whereas in children, we're really comparing it again to their matches in age and sex based off of percentiles, with anybody over the 85th percentile being considered overweight versus those over the 95th percentile considered obese. And there's also been some new growth charts that have been created using Z-scoring for those who are considered within the kind of severe or morbid obesity ranges for children as well as adults. But I thought it was really interesting to just think about historically how kind of our ideas of what is a ideal body type have actually influenced how we view obesity. These images actually come from a BuzzFeed video on YouTube, where they show just kind of what was the ideal body type. At least I wanted to qualify this for white heteronormative standards across time, recognizing that this may not necessarily be a reflection for LGBTQ communities or other racial or ethnic groups. So we have kind of an Italian Renaissance, and you've probably seen this from the art history that you've seen, or even just going through an art exhibit. The ample bosoms, rounded stomachs, full hips, and fair skin were really considered the model of beauty. When within Victorian England, you then still had kind of desirably plump, full figured, but then at least more of a curvature of the cinched waist, and that they were using corsets, which we know the health impacts of, as a way of being able to promote that figure. And then suddenly, kind of within the 20s, we have a complete shift of that being flat-chested, downplayed waist, as well as this short bob kind of flapper haircut and a boyish figure. And then there's been a lot of discussion today about kind of this slim, thick appearance, or in the postmodern look with large breasts and butt thigh gaps, and also use of plastic surgery to achieve that look. And I know often Kim Kardashian is kind of presented as like the image of that. And so some people would just say, oh, this is just naturally happening, and that it's all just kind of pop culture taste that happened to change. But I would argue that a lot of this is actually shaped by racism, and particularly even the more modern image shaped by almost this cultural appropriation, where that was often the presentation that was popular within particularly Black and Brown communities, and that girls would aspire towards. And yet it was demonized for a while, as we'll talk about. But now it's being seen as, oh, with on a lighter skinned body, such as Kim Kardashian's, it's desired, despite the fact that it was seen as problematic for anybody else that's darker skinned. And so in the book, Fearing the Black Body by Sabrina String, she really goes over kind of the racist roots of obesity, starting again in that Renaissance era, where again, initially we're seeing full figures being celebrated. So in the 16th century, actually, initially when white colonists were first experiencing interactions with Black people, they actually were recognizing their Black bodies as beautiful because they had the same shapes as the white people, and really only distinguished, oh, it's their facial figures, such as their larger noses or lips, that were seen as disfigured and not beautiful compared to the white people that they were used to and compare in their communities. Versus as we see the slave trade expand, there seems to be a need to being like, okay, if we're going to enslave these people that otherwise look like us, how can we separate ourselves from them to say, no, they're the ones who are deserving of being subjugated, while we are the superior ones. And so in that same time frame, you see that Black men and women are now viewed as lower than white people. And also you start to see the groundwork of fatness being seen as lazy, and even in conversations about white men who are at that size. Where the 18th century, that's really where race is now popularized, to the concept of this idea that each group has distinct features, and that includes biologically. So white people are being attributed to be more rational and intelligent, whereas Black people are now being seen as plump, simple, and stupid. And it's those ideas that are really kind of codifying these ideas of race. And that thinness, even if white people hadn't achieved that yet, is really seen as a sign of refinement and being able to kind of have restraint. Then with the switch to the Victorian era and the Roaring 20s, American women were actually often thin or aspiring towards thinness. And so you even had writers in Europe really celebrating them for that, and that was almost a perceived marker of their whiteness. And then also that scales are starting to become more popular. And so this is the image of the Gibson girl, who's kind of seen as like the model of white appearance as far as thinness, and celebrating that and ways to be able to achieve that. And now kind of going to the history of the BMI equation. So really, for those who don't know, it actually started by use with insurance companies. So the Metropolitan Life Insurance Company actually had a table that predated the use of the BMI equation, where they essentially used heights and weights to be able to see who is at higher risk of death. And yet most of their clients were white men. And so I think it's important to realize that even just initially, this concept of higher weights being dangerous was really within a limited population. And they found from that data that those who were over 35 seemed to have, like, the higher weight somehow was bad for their health. In 1972, body mass index was introduced as a replacement for these tables. And actually, the original equation was created by a mathematician and sociologist who really was trying to determine what is the ideal and more appearance, not necessarily in health, weight for individuals. In 1990, the Healthy People 2000 comes out and really is emphasizing individual behaviors and responsibility as a way to be able to address those health disparities that are being seen as far as Black and Brown communities having higher instances of obesity. In 1995, you've got the World Health Organization introducing classifications by BMI, and kind of arbitrarily associates that, okay, those who are at those higher levels have a higher risk of mortality. And then in 1989, obesity is then named as an epidemic in the Journal of the American Medical Association. And we'll talk a little bit more about how even that assumption was actually a poor calculation. And then in 2000, we have obesity is reduced to a goal obesity reduction is a goal within Healthy People of 2010. And actually, behind the scenes, there's a lot of lobbying, specifically those who are within the weight loss industry, to be able to really promote this as a goal to be addressed on the national level. So then as we get kind of pediatric BMI and the limitations of it, reality of it is that with BMI generally, what we're really doing is treating fat and latent mass as the same because of the fact that we're only focusing on weight. And so the assumption is just because you have a higher weight, likely you also have a higher body fat. And I think we can all think of people like athletes where that's not actually true for. And so what that leads to is that 1/3 of overweight children will actually have a normal body fat. That BMI as a predictor of body fat is actually not as accurate for Black youth as it is for white youth, and that BMI alone can actually miss higher body fat in Asian youth. This is a quote that actually comes from a physician who works within obesity medicine, but was not a part of the AAP guidelines, who released a blog really kind of commenting on the inaccuracy of really focusing on BMI as a screening, saying it is vital to recognize the limitations of BMI as a single measure, as it may not accurately reflect an individual's overall health or risk factors. And so it really just kind of made me think about the fact that a lot of physicians and journals, and therefore media, are really just listing these blanketed numbers of how many people are impacted by obesity, when realizing that really that number and calculation for obesity is coming exclusively from this BMI measure, that again has non-medical roots and also has inaccuracy in current practice. So when we're saying that 13 million or 19% of US children have obesity, how many of them actually are at higher risk for the conditions that they're concerned about, such as asthma, type 2 diabetes, and depression, if we're only using this proxy? So I just wanted to point out that I think we've kind of gone from this initial idea, even though the CDC is still referring to it as a screening tool, into an implied, and I would argue, especially with the AP, almost an official diagnosis of obesity, not just as a screening for these other conditions, but really as a problem within itself. These are just some media that I also wanted to point out, again, with the stigma. And so you've got actually this hospital that was really focusing on stopping this childhood obesity epidemic by showing these images and dramatic black and white of children in larger bodies, and almost kind of poking fun in them at the way, saying, warning, it's hard to be a little girl if you're not. I want to say this came out in about 2005 in Atlanta, and it was interesting to see that those who were behind this campaign really stood by the stigma that they were promoting from it, saying like, no, this is the whole point, really, to get people to recognize that it's a problem. Or again, focusing on higher weights on scales, or again these kind of images of people who are at higher weights enjoying treats that we all hopefully should enjoy. I think ice cream is delicious; it's one of my favorites. But somehow the assumption that this boy should not be eating ice cream just because he's at a higher weight, or that somehow he's now breaking the skateboard. Or focusing on, again, these kind of complications of obesity. So this comes from Nationwide Children's Hospital. And again, the image shows a child in a higher body and pointing out each body part, what health conditions can be related to that higher weight, as opposed to necessarily focusing on what intervening factors may put them at greater risk for that. Or even just this concept of the obesity epidemic. I think the word epidemic has a different meaning, a stronger meaning for us nowadays after living through the pandemic. And so just this idea that somehow obesity is contagious. The American Health Medical Association really formalized this idea of obesity as a disease in 2013, stating it as multiple pathophysiological aspects requiring a range of interventions to advance obesity treatment and prevention. So now moving on to the AAP guidelines, which just came out this year. So first, I did want to acknowledge that I think they really tried to bring in certain principles in mind, such as health equity, racism, weight bias, and stigma, and adverse childhood experiences. And so their opening statements really acknowledge the ways in which all of these factors may put children more at risk for obesity. They also defined obesity as a long-lasting, persistent negative health effect with attributable morbidity, mortality, as well as social and economic consequences that can impact the child's quality of life, and specified as a chronic disease with escalating effects over time. They mentioned kind of risk factors in these broad categories: policy, neighborhood and community, family and home environment, as well as individual. And I think initially when I was reading it, individual sounded like things that are modifiable to the child, but in fact, they actually were more predisposed based off of the conditions that they were born into, such as genetics, prenatal risk, or childhood risk. And then also listed kind of what are the comorbid conditions to be concerned about, things like high cholesterol, prediabetes, things that we think about, down to kind of menstrual abnormalities, mental health, especially important for this population that I'm speaking to right now, and even other things like idiopathic intracranial hypertension. So really the only things that are kind of listed that are modifiable that a family has the ability to impact are kind of the things that fell within family and home environment. And so that was things like how the families feed them, how often they're having sugary drinks, portion sizes, snacking, dining out versus having family meals, screen time, sedentary behavior, sleep, as well as exposure to smoke in the home, stress, and again, those ACEs. And I think it was just important to acknowledge, I think often this chart on the right is used as a way of acknowledging that the factors that contribute to a community's health are really only have a limited impact as far as healthcare, and yet that's something that we spend a lot of money using. And so healthcare activities really only play about 20% into a community's health. But I thought it was also really helpful to acknowledge, for the sake of, again, how much of this can be modifiable, that really only 30% of that health is because of behaviors. And so the majority of that, especially when we think about the things that children don't have impact of, we're talking about those socioeconomic factors and the environment, that's a path. And so I think it was just really important to acknowledge, as far as giving families this responsibility to fix obesity, or even putting that pressure on providers to help families fix obesity, that really half of the factors that are impacting families are things without of their control. So this was kind of an algorithm that was put out by the AAP that really goes over what is the screening for this. And they wanted to use the word should as a part of their really strongly recommending, but of course not requiring, that every provider address obesity and overweight within conditions, and defined, again, as we reviewed already, what those categories are in addition to it, the severe obesity for those who are 120% of the 95th percentile. And what their recommendations were, strong recommendations, came out as a green check, versus those who had the scale was kind of more saying like, didn't be able to weigh that based off of your clinical input because there was not strong evidence for that based off of their literature review. And so really for children, for example, who are over 10 and are considered in the obese category, that they're recommending not only a comprehensive history and exam, but looking at blood pressure as well as a fasting lipid to screen for cholesterol, as well as some type of screening for diabetes, and screening for non-alcoholic fatty liver disease or steatohepatitis with an ALT. Versus for children under 10 who are also in that obese category, they're recommending just the blood pressure and the comprehensive exam, not necessarily that fasting lipid. Versus for those who are overweight, they are recommending that fasted lipid panel, but again, looking at the kind of liver impacts or diabetes, a little more equivocal. And then for those who are under 10, just looking at the blood pressure at that time. And then I think where there was a lot of controversy was more in kind of what referrals were being made, because I would say that the kind of evaluation was not very different than what they'd recommended previously. And so really across the board, everybody should be getting some type of motivational interviewing as a way of being able to address weight, but that they're recommending intensive health behavior and lifestyle treatment, which has been shown to be clinically effective if it's 26 hours contact hours of training within a year for anybody who is 6 or above in either category. And that really for those who are 12 and in the obese category, recommending weight loss medications, and kind of with a little qualification. I think specifically they were thinking of those in the severe obese category, recommending at least a referral for evaluation to bariatric surgery for those who are greater than 12 and in that range. And so they also kind of provided these little check marks of kind of like almost a clinical workflow that really goes through those same recommendations again, and really emphasizing the importance of communicating BMI and weight status to patients and families at every visit. And so I wanted to also discuss a little bit about the USPSTF recommendations that just again were released on Tuesday. It was interesting because I'm actually a spokesperson for the AP, and so they were the ones who actually made it made it known to me that these recommendations had come out and were pointing out some of the similarities and yet some of the differences between them. So the draft is currently available. It has not been formalized, and I think there's going to be a comment period, which it's in now, before they'll release the final recommendations. But it does recommend, and similarly, that children 6 or above should be recommended to some kind of comprehensive intensive behavioral intervention. It gives it a B grading, which is a moderate net benefit and no harm. And I kind of was curious for myself of how does that compare to other gradings that they have for things that are relevant to adolescent medicine. So there's higher evidence for things like cervical cancer screening starting at 21, as well as HIV screening starting at 15, but similar evidence for things like anxiety, depression screening, chlamydia and gonorrhea screening for teenagers, as well as hepatitis C screening for adults. It's interesting, these guidelines make no specifications for overweight children as opposed to the AAP guidelines. There's also no recommendations for medication use, and they commented specifically on that there's no evidence for their benefit long-term, and so that's something that would still need to be determined. There's also no comments on bariatric surgery, and the reason why they say it is because these were supposed to be primary care guidelines, yet it's interesting that the AAP guidelines do have that recommendation that primary care providers should at least be making that referral, not necessarily commenting on whether or not the patient actually is seen as eligible and goes through surgery. And I also realized that this comments their draft did not comment on, for example, the screening for diabetes and lipid screening, but they do have separate guidelines that have been updated within the last year that say that there's insufficient evidence to support those within those who are under 18. And so going back to the AP guidelines, their way of really being able to address weight stigmas, they kind of were talking more about it's a way that doctors talk about it as opposed to the issue itself. So they mentioned that one change is asking for permission to discuss BMI or weight, which is something that I do use in my practice. Another one was avoiding labeling by using person-first language, so referring to a child with obesity as opposed to obese child. This one I question, especially going into the third as far as words that are perceived as neutral, because there actually are studies that have shown what terms families appreciate and which they don't like, and obesity actually was on one of the list of terms that families did not like and did find stigmatizing, and so even the use of person-first language doesn't necessarily address those research preferences. The phrasing that they recommended as preferred was an unhealthy weight, gaining too much weight for age, height, health. Offensive terms being obese, morbidly obese, large, fat, overweight, and chubby. And I would argue that I think the terms that families appreciated were more kind of terms like higher weight or high BMI, as opposed to making judgments as far as like unhealthy. And also they really wanted to emphasize that treatment does not include recommendations for restrictive eating and dieting. And I know that that was a huge concern when these guidelines have come out, and I think many of us in the adolescent medicine world have seen on the other side where patients unfortunately have taken these messages about you need to lose weight too far to heart and then come back with eating disorders. And the goal they really were trying to emphasize is a focus on developing a healthy relationship with food, and that supposedly this therapy that they would have access to would give them the tools to be able to do that. So I kind of wanted to share really what my own journey in this has been as far as shifting away from that obesity paradigm and hopefully getting back to at least some of the ideals that were mentioned in these scientific guidelines and addressing patients' health, but without necessarily having it be such a focus on weight. So for me, this moment was realizing as a resident that I really was trying to address these conversations sensitively, because I had been on the receiving end of how hard they can be. And so I remember I was out on my WAMI rotation. My residency requires that we spend 2 months in a rural area working in a primary care practice. And I was seeing a lot of 11-year-olds because they all had their shots that were due. And so the sweet little 11-year-old girl comes in with her mom. And as a part of her well visit, I'm remembering, okay, growth chart, growth chart, growth chart. Like I'm supposed to bring up the growth chart and show it to them and explain it and where she falls on it and make recommendations based off of that. And so I pulled up the growth chart and I'm explaining to her that I noticed within the last year that she has gained weight, and now that puts her in this obese category. And the girl immediately starts to cry. And I, really in the moment reflect, I was like, did I say anything that was outright offensive or rude? And no, I hadn't. And I think just really the reality of saying like, hey, there's now something wrong with your body was just enough. Like the girl picked up on the memo, like no matter how nicely I was saying this, that I was basically saying something was wrong. So in the moment, He's crying, and I'm remembering the fact that I cried in the doctor's office and feeling awful about the fact that I'm now perpetuating the same harm that I've experienced. I was really desperately trying to dig myself out of this hole and really focusing on all the great things that her body is doing. And so we talked about, well, what sports is she playing? And she was active on a soccer team. Or how is she eating? And she really was having well-balanced meals. And I realized when it came to the actual activities of what she was doing everything that I would want any young teenager to do regardless of where they fell on the weight spectrum. And yet only because she was at a higher end and had recently made that change was I suddenly having kind of a harsher message to her, even if as much as I tried not to, versus a peer of hers who may have been on a lower point in the growth chart. And that for me just made me realize, like, okay, even the whole like approaching this sensitively, such as recommended by the AP, really just didn't feel like enough, because patients were still picking up on the fact that I'm saying something's wrong. And so thankfully, I actually came back to residency and had a dietitian of mine introduce me to some of the topics that we're talking about. But I really also first wanted to pause and talk about, well, what is weight stigma? Because I think a lot of people, whether approaching this on an obesity focused way, or in my approach from more of a health behaviors and kind of nutrition sensitive screening way, we're really ultimately trying to prevent this harm. So weight stigma is defined as a social devaluation and denigration of a person because of their, and I put in parentheses excess, because I would just say higher body weight. I think even the term excess is still putting a qualification on that. And how that looks is bullying, teasing, victimization, implicit bias, as well as internalized weight bias. So it does have both physical and psychological impacts. We see that the physical impacts is it really can increase physiologic stress, causing increased inflammatory markers and cortisol. It actually can really undermine efforts to lose weight if that's the goal, or even maintain weight, because hunger can lead to greater fat storage and cause weight gain as a part of that stress. We also see patients actually being at higher risk for the metabolic conditions that we're assuming are connected to their weight, and that we're ultimately trying to avoid, leading to higher rates of stroke, heart disease, and diabetes. And also can lead to decreased physical activity and efficacy, just because children feel really demeaned by this. And on the psychological side, which I know many of you here have an impact on, we see higher rates of depression, anxiety, low self-esteem, loneliness, suicidal thoughts, poor academic performance, as well as a reduced quality of life and disordered eating. And I think I specifically want to focus on these because often these psychological impacts are seen as a factor of obesity, almost as a reason to address obesity, as if patients were saying like, okay, you live in a higher weight or in a bigger body, people are mistreating you as a result of that. And now it's your responsibility to fix that as a way of being able to reduce this, as opposed to saying this is probably more a quality of the weight stigma world that we live in. And perhaps we should be more accepting and understanding and embracing of higher bodies, recognizing them as a aspect of diversity, so that they don't feel bad about themselves and are experiencing that internalized weight bias. And so that dietitian actually just gone to a conference and introduced me to Health at Every Size, a movement that has very much grown even than when I first heard it, as far as the tenets that it uses. And I actually loved these photos that were from a campaign, I believe, a couple of years ago from Cosmo, really just emphasizing that there is body diversity, and no body just by appearance automatically is unhealthy. And in fact, it's really more to do with, again, kind of the behaviors that people are participating in, whether that be what they're eating or how they're participating in physical activity, whatever that looks like from their abilities, as well as kind of appropriate screening for their labs. And so not surprisingly, when these images came out, there was a lot of pushback online about promoting obesity and the dangers of that, as opposed to being able to, again, move to this idea of health being really more of an internalized thing and not just an external assumption. So the Health at Every Size has several kind of guiding principles that have changed in language, but the ones currently are weight inclusivity, health enhancement, eating for well-being, respectful care, really referring to, again, how patients are interfacing with healthcare systems, and life-enhancing movement, really describing that very broadly, with the reality that given different abilities, especially like disabilities or age even, that movement will look very different for different people. And also with this kind of introduced to kind of different terms. So one of them being body positivity. I feel like that's one that people are often very aware of. It's the acceptance of all bodies, regardless of size, shape, skin tone, gender, or physical abilities. And it's really challenging unrealistic beauty constructs from society, which should not determine that someone's self-worth or value connected to their body. And also, some people have argued that body positivity is almost maybe just like a physical version of toxic positivity, this assumption that we all should feel amazing about our bodies without accepting the reality that the world sucks and how it views us. And so perhaps that's asking too much of people and may not even be necessary for them to care for their bodies appropriately, as opposed to body neutrality, which is more of a middle of the road approach that saying you neither have to love nor hate your body, but accepting and having respect for it and prioritizing its function about what it can do rather than its appearance. And so you may find that clients that you're seeing may identify with one or both of these, or even you can introduce these ideas as a ways for them to be able to have a healthier relationship than self-hate or internalized weight bias with their bodies. And then I kind of went on my own little book journey of trying to read more and understanding like, okay, well, how can I do better? And realizing that at least at the time, I didn't see any articles giving specific guidelines for clinicians or even evidence different than what I was reading. And so I kind of wanted to share some of the highlights from the books that I've read, as well as this serves kind of also as my recommendation for you all if you wanted to read further. So the first is Body Respect, and this comes from the authors who actually introduced the Health at Every Size movement. First, really stating that all bodies are good bodies. And I just want to sit with that thought because often it doesn't feel like that in the medical literature and really the medical approach to this, especially with these strong recommendations at such young ages. So this book really talks first about kind of the idea of the obesity paradox, which really finds that especially those who are in overweight category or at kind of stage 1 obesity, that we actually don't see when we look at their life expectancy that they are dying sooner than those, and in fact, maybe living longer than those who are considered at normal weight. Or that weight-related conditions, again, now being seen more as comorbidities by the AAP, in fact, seeing them really just as associations. I feel like anybody who's taken any kind of psychological research class, statistics class has been heard like that correlation does not equal causation, and yet it's so interesting within the obesity worlds that there's just this causal relationship that's automatically assumed. So really in my practice, I try to separate those two things, and I think the literature does support that. Or that health improvements can occur without weight change and that weight loss alone does not change outcomes. I actually brought this up to a provider at the weight and wellness program at Lurie Children's and said, are you really recommending weight loss for patients when it's been shown that patients will actually have a change, for example, in their prediabetes just from changing health behaviors, whether or not their weight has changed. And they actually mentioned that really they only are supporting weight loss if that's a goal of the patients, but that otherwise it's not actually a goal of theirs, given the fact that it's not required for those health behaviors to change. That healthy bodies will maintain a stable weight and that yo-yo dieting can actually raise that set point. And so that's something that I'm often educating patients about when we're starting these behaviors, saying like, actually, these behaviors may or may not change your weight, but it's okay because I actually don't necessarily need that weight to change. And that pediatric BMI categories were really just arbitrarily set. So basically it started in 1962 looking at weights of children within the US, and that they just decided based off of the range of weights, if you were higher than 95th percentile, that you were considered obese, and that if you were below the 5th percentile, that you were considered underweight without necessarily using evidence at the time to support those. And that finally adult obesity was set to 30, despite research showing that kind of those health concerns that we were talking about, things like diabetes or high cholesterol, really seen at the 40 plus range. And then again, when we think about kind of the systemic issues that really are contributing to obesity, I love this quote saying, when families and communities have the resources and power to take control over their lives, their health improves. And so how much of this is really more of a systemic problem as opposed to an individual problem? Okay, so the next book was The Body Is Not an Apology, and this is by Sonia Renee Taylor. She really goes into kind of body issues broadly, with weight only being one of them. And so I loved how she really talked about the relationship we really have initially with our bodies and being in awe in our bodies. I am just seeing this in live right now with my 5-month-old who has discovered her feet and how her feet are the most fascinating thing, and that she just loves them, and that, she has no concept of her body being bad, and that the goal is really to try to get back to that place where our bodies are reverent. And that body shame was given to us through experiences with peers, family, and media that disproportionately impact diverse groups. The idea that really there's kind of layers of, thinking of, for example, those who are Black males, and even particularly at higher weights. And that's something the next book talks about more, that it's not just the higher weight, but also being Black and being male, that particularly when we think about the police state that we live in, how much their bodies are really negatively impacted, and how we internalize those thoughts and this idea that our bodies are wrong. And also she really pushes this idea of going beyond self-acceptance and body neutrality, really to this place of radical self-love, and kind of really getting back to a place of embodying the self-love that we already have, because again, she's saying that this is something that we have innately. She mentions creating a radical self-love world is an inside-out job. How we value and honor our own bodies impacts how we value and honor the bodies of others. And so by starting with ourselves, we are hopefully getting to a place where we, by honoring ourselves, can appreciate the diversity of other people. She introduces these 3 pieces, making peace with not understanding. And so almost kind of having just this faith of like, hey, bodies are good, without trying to figure out why we may feel bad about our bodies, or we may not fully understand all the inner workings of our body, to make the peace with difference. And again, that's kind of appreciating the diversity of bodies and their abilities and appearances, as well as making peace with our own bodies and just getting to a relationship of that this is the body that I live in, this is how I am, how can I embrace that? And she also kind of introduces these 4 pillars as far as skills for being able to approach our and other people's bodies better, taking out the toxic. That includes, like, for example, cultivating a positive feed on social media. So instead of looking at all of these images of thin that make you feel bad about your bodies, how can you look at, for example, images of people at various weights? So I'll say for myself, I realized before getting pregnant that all the images I've seen of people pregnant were people who started off at lower weights. And so I specifically looked for, there's an Instagram account called Plus Size Pregnancy that was showing like images of people during the maternity shoots who were at all ranges of obesity. And that allowed me to feel like, once I got to kind of particularly later stages of pregnancy, that I didn't feel huge, because I just had never compared myself to anybody other than those who started at a lower weight. Unapologetic action as far as pursuing our health and not really basing that off of trying to appease other people. Mind matters, really looking at our thoughts, and then collective compassion, really kind of getting in a compassionate relationship with ourselves. And then the final book is Belly of the Beast by Deshaun Harris. And he really tries to put all these ideas together, really arguably in a very radical way of being able to say that it's really not about the individual at all, but more about society. So he points out that, yes, self-love is important, but it can't actually eradicate anti-fatness, and that really only the destruction of the socioeconomic political structures can do that. That fatness is really considered undesirable because of its connection to Blackness, and so that anti-fatness is arguably perpetuated and created because of anti-Blackness. That fatness was created to make health inaccessible to Black folks. That somehow there's almost this carrot that we're hanging over Black communities, saying here's this goal that you can aspire to, but you can never actually reach. And that actually I talked about before about kind of the obesity epidemic, and that in 2004, the CDC made a report stating that there were 400,000 additional deaths that were attributable to obesity. And that in fact, after a recalculation, and despite others coming out saying that that actually wasn't true, that the impact of that has continued. And this idea of the epidemic is actually based off of that false calculation. And then there were a couple quotes that stood out to me from this. One was, the world's obsession with obesity and being overweight is less about health. It is more about the cultural and systemic anti-Blackness as anti-fatness that diet, medical, and media industries profit from. And then second one that really fits with my own values of Black liberation. The work that I do is that Black liberation is the end goal, and for it to happen, fat liberation must also be a part of that goal, not body positivity, but freedom from the confinement of cages. So again, kind of raising these 2 systemic issues as opposed to individual or medical problems. Okay, so now bringing it back to clinical spaces, this is kind of the system of which I am currently using, and I want to point out, now my last slide will demonstrate that this is kind of something that's constantly changing. So really looking at weight as a trend and not a status. When a patient comes in and automatically is just, for example, there's a patient of mine who I don't never seen except for this one visit. So I had exactly 1 point on the weight, height, and BMI chart. And she said, well, am I at a good weight? And I literally told her, I was like, I actually can't tell you because I have no idea what you've been before. Just an individual number does not actually indicate weight. And I wanted to be able to point these 2 things out. So on the patient on the left, you have had a BMI above the 95th percentile, and then quite precipitously dropped. Anybody who works in the eating disorder space understands that this is a very concerning drop. And when I asked her, like, oh, well, what is your goal weight? She said, I want to be 110 pounds because it seems like a good number. And at that time, she, I believe, was about 120. She has since gained weight as a result of my medical care. And so some people just seeing that weight alone at her lowest point would be like, she's at the 50th percentile, great, without acknowledging, of course, that there were significant health impacts such as bradycardia and actually amenorrhea, basically low heart rate and a loss of periods for those who don't know medical terms, that occurred during that time. And then yet on the other side, this is a patient that I saw at a high school, and we do a Bright Future screening as required by the state for anybody that I see in the school-based health center. And there's a question to ask, are you concerned about your weight? And whenever I see that, I ask like, oh, well, what makes you concerned about your weight? In her case, she mentioned, oh, my doctor said that I need to lose weight. So then I pull up her growth chart and I'm seeing like, actually, we've known you for a very long time because we're also her primary care provider. And she quite beautifully has been following her BMI with along this 85th percentile and overweight. And so I was really shocked to kind of see like why suddenly at the age of 17 are we saying that this is a problem when in fact she really is proving the points that we've mentioned of like, hey, when bodies are have access to the regular activity that they need and the food that they need, they actually do a very good job of growing at a predictable rate. And so I was telling her, especially compared to the left, this is actually probably one of the more healthy growth charts that I've seen. And I don't think that there's anything wrong with your weight. And she actually became teary-eyed just even hearing that positive feedback, again, just proving the point of how negatively these comments, even when well attended, are impacting patients. And so actually one of my mentors from residency said a quote that I will constantly quote in the space of every growth chart change tells a story. And so I'm really more interested in that story and asking about it non-judgmentally. So these are kind of the universal practices that I use for every patient that I'm seeing. One is I do still feel like within children and adolescents that weight is still an important vital sign, but not because of just the absolute number, but again, being able to identify those trends. And I find that it often can be a proxy for understanding what changed in a young person's life, whether that be additional stress or mental health concern, that only because of noticing a change in weight and asking about it in a sensitive way, I've been able to identify that issue, because otherwise patients aren't necessarily coming in to tell me like, hi, Dr. Fenton, I have an eating disorder. Sometimes, but not always. And so seeing that change is actually what may prompt that discussion. And then I note any changes up or down and bring that up for discussion. So I might say things like, I noticed a change in your weight since the last visit. Is okay if I talk about that? And then asking, did you notice that change, to see whether or not it was intentional and how do you feel about it? And if there were loss where you're intentionally trying to lose weight. And I think often, unfortunately, doctors may move automatically to weight loss equals congratulations, as opposed to acknowledging that actually that can be very unhealthy conditions that are leading to that weight loss, such as depression or trauma, or even just a lack of food access, as opposed to automatic assumption that that's somehow an improvement in their weight, especially if it's happening too rapidly. And I also, on the other side, don't discuss weight during the visit unless it's necessary. And so there's this concept both within the trans health system, but as well as in kind of the fat I guess fat acceptance space of kind of this broken arm syndrome that people describe, kind of coming in about a problem that's completely unrelated to weight, and somehow the doctor still finds an excuse to be able to make it about their weight. And so I intentionally, unless an issue is directly related to that, I don't. I'm thinking of a patient recently who mentioned that she actually was trying to get pregnant and hasn't been able to, and was nervous to bring it up to me, who I was meeting for the first time, because of the fact that she was worried that it was going to be blamed on her weight and that a previous provider had done that. And so I pointed out to her, I said, that actually would be malpractice of me to not investigate this further by having appropriate labs being drawn, instead of just telling you that just because of your higher weight that that's impossible, knowing that, of course, people at weights of all over the spectrum have been able to successfully get pregnant and carry pregnancies. And it would be appropriate to be able to evaluate everything first before making that assessment. And then I also, for any patient, try to avoid discussions of ideal weight or calories. So often parents will ask me like, oh, well, what weight should my child be? Or what's a healthy weight for me? And even kids will tell me like, oh, I should be this weight because this is what I looked up as the average weight for somebody my age. And so if those questions come up, I really educate them on why I don't use those things. But again, because this is still a dynamic age process, that those aren't helpful. And I, of course, also don't want to, in any of my counseling, replace a new problem with their concern. And I think that's what's sometimes happening with when providers are focusing on obesity. The patients will then come back and have taken that message all the way to heart, and then now be obsessed with calories when they weren't previously. And we're, setting the groundwork for an eating disorder that didn't exist previously. And finally, discussing well-balanced eating and physical activity across the weight spectrum. And so previously, it was almost this idea, if a patient was at the 50th percentile, didn't matter what they were eating. Cheetos every day, great. Not exercising, no problem. As opposed to having kind of these very intense discussions about, well, what are you eating and how are you exercising for patients who are at higher weights? And the truth is, of course, these habits are important for children across the weight spectrum. And so using motivational interviewing to support creating one nutrition and one physical activity goal. And so I'll ask questions like, how many meals are you eating per day? What meals do you skip and why? Constantly fighting the battle with my teenage patients for not eating breakfast and really explaining the importance of metabolism in eating throughout the day, as opposed to kind of having the starvation mode because of that infrequent eating. Even just asking, how do you feel about your body, and asking every patient that, realizing that these body image issues can occur regardless of where they fall on the spectrum. And are you getting any physical activity on a regular basis? And asking more specifically, what do they do? I prefer the word physical activity than exercise, as well as using kind of nutrition instead of diet, because again, I think some of those terms have a certain very limited stigma or idea of what those mean. Like, for example, families will tell me, oh, we have a treadmill at home. And I look at the teenager and I'm like, but do you like running on the treadmill? And they say no. And I'm like, okay, then that's not the kind of physical activity for you. Really looking at kind of setting up long-term goals for things that they'll enjoy. And then as far as how I screen for health conditions, I kind of reference it by saying, as a part of your checkup today, I'd like to do a blood test to screen for diabetes, high cholesterol, and liver disease. And I'm still following the AP recommendations as far as when to do those. But I also still preface those by saying that these conditions are often considered to be related to higher weight, but they're also impacted by nutrition, physical activity, as well as family history. So it's less of a like, you're at risk just because of your higher weight, but perhaps there's other factors that we can get into that may be playing a role in this. And then really focusing on, again, that kind of motivational interviewing and the outcome of those. So making some great goals that can reduce your risk, but it'll be helpful to know if these things are occurring so that we can address those while you're continuing to improve on the goals that we've mentioned. And then let's say, for example, a patient does come back and does have pre-diabetes, and these are some of the language that I might use. So, I would say some doctors might advise that you lose weight, but I actually don't care about your weight because it is not an accurate indicator of your health. There are people who are thin with significant health problems and people at higher weights who can run marathons. That really, I care about you and your health. And so then let's focus on those health behaviors, because you can't directly change your weight. And I think that's the other thing is, patients will tell me like, oh, my goal is to lose 5 pounds. In addition to asking why, the reality is I tell them, I'm like, you can't just go on a scale and say, okay, I'd like to delete 5 pounds, please. And in fact, that may not actually even be necessary to be able to change these things. So instead, I really want them to kind of improve their self-efficacy by focusing on kind of the primary behaviors and outcomes, not the secondary ones. Like you can be able to say, hey, I worked out 5 days this week, or I ate more servings of fruits and vegetables. You can't necessarily control like I have lost weight, nor, as we've talked about, is that necessary even. So I'll say often those health problems resolve before the weight even changes. Everybody has a weight that it likes to be. So it's possible your weight won't change after all of your efforts, and just letting them know in advance that that's okay. Because I think that's the other thing is patients will often be unmotivated to continue these behaviors because they've had such an emphasis on you need to lose weight, or weight is the outcome that we're looking for, when in reality, the prediabetes can improve even without that changing. And finally end with, I think most people know what they need to do. It's just a matter of finding the time and commitment to do it. And the drastic changes don't work. The goal is to make changes you can continue long term. And so really trying to break that down by saying, what would a baby step towards a healthier eating look like? How about physical activity? We talk about like, okay, what's something that you can do in the next 2 weeks? So, patients may mention like, oh, I want to go to the gym every day. So of course I'm like, okay, first we need rest days, but also like going from 0 to even 5 to 6 times a week is really just more of a setup for failure. Like, how about for these next couple of weeks, we set up that like if the gym is something you want to do, you go once or twice a week and start setting that as a regular habit and then build from that. Because really the goal is to try to set up a whole healthy lifestyle long-term, as opposed to these short-term efforts that may succeed, may not, and then may ultimately fail in the long term. And then I just wanted to end with the fact that I am still learning. So I saw a patient recently who came in for a checkup, and then I was 18 years old, senior in high school. So of course I was like, okay, you are due for your cholesterol screening now that you're an adult. And I also noticed, oh, this patient was on a medication that made their liver enzymes increase. So I said, you're not on that medication anymore. Let's just go ahead and check it. And then I was like, you know what? I'm already doing 2/3 of this metabolic workup. Like, why don't I also add on a diabetes screening. And so based off of BMI, this wasn't actually something that the patient should have gotten. And at least within the immediate family, parents and grandparents, there were nobody with a history of diabetes. So I ended up just going to order it. And unfortunately, to my surprise, found out that this patient actually was in the pre-diabetes range. So my practice is usually to call the patient back so that we can spend some time not only going over the result, but also talking about those health behaviors, making referrals to a dietitian, that kind of thing. And so actually, had a medical student shadowing with me that day and told them, okay, this next patient has pre-diabetes, we're going to do some counseling. So we go in the room, and even she admitted afterwards, she's like, I hate to say, I had a certain image in my mind of what this patient was supposed to look like, and he was not supposed to look like that. And again, just really emphasizing how even medical education is automatically making these assumptions about what patients need. And to my case, I'm glad I did get this lab that I had no intention of ordering because the guidelines didn't require it of me. When I mentioned it to the family, they're like, oh yes, a lot of his uncles have diabetes. And so those were people that, that extended past the family history that I had received. And again, based off of just his weight alone, it would not have been seen as a risk factor. So I have just reminded for myself that I'm constantly evaluating this, and that in fact, these health conditions are more related, of course, to family history, genetics, and even just the social and economic conditions that are making patients more vulnerable as opposed to weight, and him really demonstrating that, because based off of weight alone, he should not necessarily have been at higher risk. So that is all that I have for today. So I think we have about 30 minutes. I see that there's some comments in the chat and some questions, and I look forward to being able to answer those as well as any others you have. And thank you so much for your attention and time today.
Thank you so much, Dr. Fenton, for your time with us today and sharing your expertise and your experiences. Such a powerful message that you delivered, and one that I wish many, many, many more pediatricians and adolescent medicine docs had. I have a question, and anybody else who has more questions, please feel free to pop those into the chat. But starting with, I guess, two questions. But first of all, starting with, I'm so glad you shared the AMA 2013 definition of obesity, a disease with multiple pathophysiologic aspects requiring a range of interventions to advance obesity treatment. That seems like a bit of a circular sort of definition, right? Especially given what you pointed out about how powerful the diet lobby was and has been in all of this. When you think about people living in larger bodies or people at higher weights, do you believe that obesity is actually a disease? Because to me, it sounds like a made-up construct embedded in anti-fatness, anti-blackness, that has been used to, there are associational studies, right, that we all are well aware of on a population level scale. Many of those lacking in diverse representation, but no causal studies that I'm aware of, right? So do you believe this is actually a disease? And then a follow-up question would be, why even use the word?
Yeah, so I do not. I see it more as a aspect of diversity and a reflection of, again, kind of like there are certain factors as far as even just the food that we have access to, the like screen time, even the increase in like internet and phones and all of that, as a like weight overall may have increased as a result of these factors that should be addressed. But the concept of it being a disease and therefore something worth treatment, again, I'm with you that like, one, the evidence doesn't necessarily show that causal relationship. We're somehow accepting in this space that association equals cause. And yet in any other area, we're very much like, oh, correlation does not equal causation, except for obesity, apparently. And then I think the second thing is you're ultimately sending this message to patients and families like, that weight loss is required, that weight loss is hard, that weight loss will often fail, and that this is a chronic condition, but it's still a disease. And so then there's no hope in that message to be able to say, hey, very likely you're going to live with this your entire life, go up and down, and yet that's the course of this, without necessarily proving that it has actual impact on their health, as opposed to, I think of, addiction may also be considered as a chronic condition. And yet with that, we're saying, okay, there actually are negative impacts as a result of addiction. For example, addiction to cigarettes can lead to lung cancer. So we know that there's no other exposure like cigarettes that can continue that. So even if you may have relapsing and remitting condition, it's worth trying to reduce it because it's actually impacting your health, as opposed to with obesity, that higher weight in itself is not doing that, but perhaps the exposure to exercise. That's why I try again to break it down to what are the health conditions that might be contributing to that higher weight for that person, or that increase in weight for that person. Those are the modifiable factors that can improve their health, in addition to us as healthcare providers, or in the healthcare space, what advocacy are we doing to make sure that patients actually have control, well, at least have improved benefit of the 50% that they can't control, such as those economic and social factors.
Great. And then I'm also so glad that you spoke about the USPSTF draft recommendations. I had the chance, I saw it in the AMA news, I think yesterday. So you defined the B grade recommendation of intensive health behavior lifestyle therapy, and that B grade recommendations are deemed to be of moderate benefit and no harm. And when you talked a lot, and patients I see all the time are harmed profoundly by weight stigma, right? I don't know how it seems like that piece is it's completely people are turning a complete blind eye to the harm of weight stigma, because I don't know how you have a conversation with a family that I'm making this recommendation to you based on your BMI, right? I'm making, the recommendation is rooted in the BMI being above the 95th percentile. So I'm making this weight-based recommendation for this therapy that's, by word of mouth and how I'm trying to present it to you, not about your weight. We're going to focus on lifestyle. We're going to focus on your mental health. We're going to focus on, all of these other social determinants of health. But really it's about their weight, right? You wouldn't even be having the conversation if you were truly practicing weight neutral medicine, right? So how are we saying, there's no harm in this when there's a robust literature that shows the harms both physiologically and from a mental health perspective of weight stigma?
Yeah, I think first it's certainly the challenge of how that information is being introduced, especially if, again, kind of the focus of incorporating these behaviors is coming from a place of it's because there's something wrong with your body or because you're at a higher weight. And I would argue, I guess, for me, it seems like almost those recommendations are supporting what I am and encouraging everybody to do for every patient, as opposed to I'm only giving you this type of counseling because of your weight. And I think their point is still because they're motivated by weight loss as the outcome. They're saying for this group, 26 hours at least has led to weight loss. And so I certainly don't share that same value of needing weight loss to be the outcome, as opposed to, improvement in health based off of those nutrition sensitive conditions, or, perhaps for patients who are, done growing, I'll generally recommend, okay, the goal for you generally is probably to kind of maintain your weight. It doesn't necessarily have to be drastic, but there's not necessarily any physiological reason for them to continue gaining weight. And so if I do see those changes, I will have a conversation around what has changed in your life that may be contributing to this, and how can we work on, again, kind of incorporating behaviors that allow them to generally stay within their set point as opposed to surpassing that point. So I think that's where there's the concern of both what content is being used, but also this idea that we're recommending it just for that group, which again kind of says that there must be something wrong with that group, as opposed to, I think this is information that every patient should be using and should be given, not necessarily at that same intensity, because I don't have that same goal outcome.
Yeah, thank you. I just want to give voice to the several comments in the chat that have said, I wish you could be my doctor. And then here's a question. So First, thank you for a wonderful presentation. And as a student, hearing the perspective advice from clinicians of the field is always wonderful to hear. I was wondering, as a clinician, what is your opinion on social media and society's standard regarding weight loss, diets, and the ideal perfect body? And particularly your opinion regarding the fad diet trends that people engage in, like intermittent fasting.
Yeah, so I think social media is definitely kind of a plus minus. I don't know that I have a strong opinion either way. I think it can be very impactful in a lot of settings, and yet also can be harmful for being able to be exposed to information otherwise. I think of one patient who came to me, actually, I think I was supposed to evaluate them for PCOS, or irregular periods, which is often attributed to be related to weight, although certainly people all over the weight spectrum can have this condition. And so I think because of having this condition, she got the message, hey, I'm supposed to lose weight as a way of being able to address this. And when she came to me saying that she was fasting and throwing up, I was like, oh, well, where did you get this information from? She's like, well, social media. And so then we talked about, okay, well, why those things are unhelpful and why they're unhealthy. And when she came back, she was describing, okay, now I'm eating more fruits and vegetables, I'm eating regularly, and I'm exercising. And I was like, well, where did you get this information from? She goes, social media. And I think she as a patient perfectly demonstrates the fact that unfortunately there is a lot of negative things that we hope patients are bringing to us as questions about, like, hey, is this a good idea? Or by asking these questions, even if you don't notice the changes in their weight, like that's where you're bringing that up. I've had plenty of patients who will talk about, like, oh, I thought intermittent fasting was a good thing, and this is how I'm, or when I'm asking, are you skipping meals? That's where that answer comes up. And that's why I'm asking that as a regular question, to be able to hopefully have an opportunity to filter the things that they're seeing. And then also, I think it's great, especially those of us who are working with young adults, to be really informed on what are positive places to be able to get information on social media, so that I'm actually recommending positive accounts to my patients, because I think the reality of them being on social media is just a fact. Like, we're not going to change that, but how can we at least change what they're seeing? And I know that there's also, at least I hope that social media will look a little different as a result of COVID, where there was an effort of realizing, like, we can't just have people say whatever they want. There actually should be some filtering of, like, here's where you go for accurate information. I think we all have seen to this day on TikTok and Instagram, if anybody mentions COVID, there's a little kind of link that says, there's information that's further. My hope is to be able to see that, especially for young adults, kind of across these health issues, so that even if the algorithm is not promoting the accurate information, if anybody is talking about something related to reproductive health or their physical health care, that there's some mention of an accurate resource that they could reach out to, because they're looking for answers. And just the assumption that something's popular obviously does not mean it's healthy. And I would argue often it's the exact opposite. Whatever is popular is not healthy. I bring that up with my patients about, like, birth control all the time, that, like, a post saying, I love my IUD is probably going to be short and not get a lot of views, but IUD horror story. Now everybody in this audience is like, ooh, I want to hear more. And that's the reason why the algorithm promotes it. And so also just teaching them to be more media literate in that way. And I think once they hear that, they're like, oh yeah, that makes sense, as a way of being able to do that. And actually there's some recommendations from the AP as well, of making as a part of our kind of adolescent health screening, talking specifically about social media and what they're looking at as a way of also being able to screen for that behavior.
For sure. Awesome. There's another question. I spend a lot of time thinking about disability and how that's tied to anti-Blackness and anti-fatness. And one of the things I keep coming back to is addressing the harm it may cause inadvertently by treating patients. For example, putting them on Seroquel for psychosis, which keeps them from the prison industrial complex, but also increasing weight, which puts them at risk of medical harm. Do you have any thoughts on this?
Yeah, so first, certainly very sensitive to the reality that, unfortunately, particularly Black children and adolescents are often overdiagnosed with psychotic conditions, and therefore are put on kind of antipsychotic medications almost as a way of controlling or managing their behaviors. And this is particularly very common for those who are within the foster care system. And so that often I've seen patients in it, and you have to ask, like, okay, who put you on this and why? And, is this something that I actually should be able to safely take off, because there really was an indication to put that on in the first place, when really all of that, unfortunately, is really more of a proxy for the trauma that they've experienced, and making sure that they're getting the mental health support related to that, and perhaps treating the depression, anxiety that these issues are presenting at. I think especially when we are much better at recognizing kind of internalizing symptoms of those conditions versus the externalizing symptoms when people are acting out, that somehow that's a problem to control, as opposed to recognizing that that's a child who's been traumatized or who's very depressed. So certainly I think their point is very valid as far as how I'm going to say that we, even as providers, are putting patients more at risk of the stigma by putting them on medications that not only do they not need, but actually then may change their BMI. And it also brings up to the point of there's often a lot of individual responsibility. And yet when we're putting patients on medications that are making them more at risk for these conditions, in my world, I'll say like that's Depo, for example. I'll have to talk to patients about, hey, weight gain is a side effect of this, but also like that's something that I don't care about, but other people might care about, or society may tell you to care about, and making sure that that's a part of those conversations as well when we're giving them all the information they need to make informed consent if that treatment is actually appropriate for them. So certainly these issues interplay, and the more commonly that they overlap, unfortunately, the more patients are vulnerable.
Yeah. Wonderful. Wonderful. Let's see. Oh, wait. Here's another one. Since healthcare is a data, specifically numbers, specific field, what are some ideas of evaluation metrics overall that you would use or prefer to use for programs or progress instead of using weight or BMI changes? Like I think this is relevant to your like very astute point about, if high intensity lifestyle intervention, behavioral approaches are indicated, if they're not about weight, then why aren't we recommending them to like, why is the screening threshold like a weight threshold versus a screening of health behaviors, right? So I think it's right in line with what this participant is asking.
Yeah, so I think
what else should we be using?
Right. First, I want to focus on, I think it should be based off of health indicators. So if there is a kind of nutrition sensitive condition that a patient is getting referred to a program for, such as, let's say, prediabetes or diabetes, then I think the outcome should be as a result of these changes that you've learned related to nutrition and physical activity, do we see a reversal of that, whether or not weight changed? And we're pointing out the fact that that doesn't matter. But I think the part that I think internally I'm still struggling with, again, with this patient that literally just saw last month, was the reality of like, if we're only screening because the recommendations are telling us to only screen for those patients at higher weight with the assumption that they're the ones that are at highest risk, like how does screening look differently? And so I actually told one of the pediatricians in my clinic, like based off of the community that I practice in and based off of the high rates of diabetes in their families, regardless of what their weight is, maybe it's just reasonable for me to incorporate diabetes screening for every 18-year-old as a part of their care because of the other risk factors that are making them risk, as opposed to this focused on weight. So I think that's the screening aspect of it is a little more challenging because I think that there's not resources particularly for me to point to. The only screening recommendations I have are saying do this for people at higher weights. And so I try to frame that in best as possible by saying it's not a judgment of it. I'm just following the guidelines, but I'm telling you that I know that more factors are contributing to this versus I think the outcomes one is probably easier because the data does support that those things can change without weight needing to change. And that's a result of those behaviors. And so maybe the intensive support is really more to be able to address that. And I guess I will say I've actually seen one of those programs approach it in a more sensitively way. Certain patients were still referred based off of that higher BMI that we mentioned is still in itself a problem. But what that same mentor I mentioned who made that comment about growth charts telling the story actually had an educational program where she taught intuitive eating. So then the focus wasn't on calories, but really just more of like relearning how to listen to your body. Those in the intuitive eating space point out the fact that babies are born with it. Like they cry when they're hungry, they pull away when they're done. I chuckle only because my 5-month-old somehow doesn't understand the second one. And she's like, actually, this is just soothing and I'll keep eating even though my stomach is full. So excluding my adorable daughter, generally they know when to stop. And yet it's really more society that teaches us, the clean plate club, you have to finish this meal. Go to Cheesecake Factory, you get, what should be probably maybe a couple of meals worth of a serving on a huge plate that's telling you that this is what you're supposed to eat. That we then, or even just society teaching us eat when you're bored or when you're sad, that makes us unlearn that. And so intuitive eating, the goal of it is really to kind of get back to that. And so she found that just by teaching patients the skill, they were then able to apply it in their lives and saw some of those health outcomes change and may have lost weight, not necessarily as a goal, but more just as a reality of now they're listening to their body's needs as opposed to listening to other sources of hunger other than true hunger as a way of eating.
Awesome. Yeah, I think, one of the things that we do very poorly in medicine is say, I don't know, or like, we don't know. right? And I think it's part of why weight-focused medicine and BMI-focused medicine is so deeply entrenched, is because we don't really know, what else to put it on, right? We know that we're over-attributing health conditions to people who don't have them and will never have them, missing health conditions and people who, based on our current tool, which I think is pretty terrible, don't even get screened.
Yeah. Well, it's both. I think the like not wanting to say I don't know, but then also wanting to fix things. Like
Right.
very much medicine's like we went in to help people. And then we all had this very humbling moment in medical school when we realized, oh, like there are factors beyond our control that we can't fix. And yet somehow in the obesity space, we're still like, okay, we'll acknowledge those outside factors, but we're still going to give you this medication because we're still going to fix this without
Right.
acknowledging like it will never be fixed, which is why we're considering it a chronic condition. And so really relieving ourselves of that. And then also to your second point about like who gets missed. I'm just thinking about the fact that because of being a first-time mom, Black, and of my higher BMI, I met criteria based off of ACOG to use aspirin during pregnancy as a way of reducing my preeclampsia risk. And I think the evidence shows that it reduces it by 30%. Thankfully, I did not experience a preeclampsia, but I had a friend of mine who was a first-time mom, white, and they did not have an elevated BMI, who actually was rushed to delivery from her 37-week appointment because of preeclampsia. And so I'm kind of on the same place where I'm just like, I'm actually grateful that I got it. And why can't that be a general recommendation because of this assumption that just somehow my higher weight is putting me at risk, when the reality is we don't fully understand this other than we see this association. And so perhaps if the benefit can prevent the number of kind of rush deliveries such as that or any other complications for preeclampsia, and the harm is minimal other than the fact that you're taking a baby aspirin your whole pregnancy, that maybe that should just be a standard of care as opposed to the assumption that this is connected to weight.
All right. Yeah, well, I guess the only thing worse than saying we don't know is we can't fix it.
Yes.
Right, as a doctor. All right. Well, I know we're a little bit over time, but I just wanted to thank you again for everything that you do day in and day out, out there, with patients, both with patients and in your writing and advocacy. And thank you for sharing with us today.
Of course. I guess I also realized that there are some questions that I did not get the chance to answer. I don't know if there's any way to be able to send those to me so that I'm happy to be able to kind of answer those and have that be sent out to participants so that everybody can get an answer to the questions.
Yes.
I will see if I can make that happen. I'll take pictures of the screen really quick and before I jump off and get those to you. And then I'll send those out separate email from the certificate, how to obtain your certificate. So that'll come separately, obviously. I don't want people to have to wait, and I don't want you to feel rushed either.
Thank you.
Great job. Thank you so much.
Thank you so much.
The comments are amazing. Well deserved.
Truly a pleasure. I appreciate everybody being here.
Bye, everyone.
Thanks, everybody.